साउंड के लिए किस में डालने का रहता है मेरा पता।
अच्छा बड़े वाले नहीं चाहिए ठीक है नहीं अगर if you want you can use this these are without wire This is much better.
It's not coming.
It's not coming. It is coming. Okay, Harish, hi. We've got you on. You need to put your speaker on and your video on.
Yeah, hold on a second. I can't start my video. I don't know why.
I will let you just wait. I may change role to attendee. Panelist. Allow panelist. Why can't you switch your video on? I had given you.
It says you can't start the video because the host has stopped it.
Yeah, sure. 1 minute. I'm just having a look at it and just trying to allow video layer. Allow panelists to start video. Yeah, I've given you the permission.
Okay, cool. Let me just take this. Okay, great. Can you hear me?
That's good. Thanks. See if you can share your desktop. Wow,
Yes.
I love your background. Wow,
So I'm in the Death Star.
wow, you're in spaceship now. I like that. So share your.
Hold on, let me load my.
Now you set higher standards. I'm going to change mine tomorrow.
Yeah, you can change. My son actually taught me this. He's 7 years old, and he says, "Dad, I saw somebody had crocodiles behind." So
So we could do that. You can put whatever you like. Actually.
yeah, it's pretty cool. So I went. I saw something on Facebook and it said you can upload, take photos of the Death Star and stuff, and upload it. So I'll send you the link, and then you can, if you want to have.
Yeah, at the moment, I am promoting this.
Right. Okay, that's better. You're right.
Okay, excellent. So we are 4 minutes away. How are
What
things
time
at
is it there for you?
How are things at your end? Everything okay? Singapore?
Everything is good here. Of course, the volume is high relatively of pickup rate of COVID patients, but mainly we're picking them up because we're actively screening, and most of the positive patients are coming from the dormitories.
I know, I heard that. That's
unfortunate thing is the reality is that they're very cramped up in there. And I think finally people have realized that this is not the way to go about things, and they are in about a year or 2 years from now, we'll have new things for them. But in the interim, we have to manage this for now.
Yeah, it's a terrible, terrible situation, isn't it?
And in the UK, how's it coming about over there?
Not good, yeah, not good. We've had huge mortalities. Yeah, we've gone past 20,000, so it's very bad.
Wow. And I just read a neonatologist, Dr. Rase or something, passed away. Young guy in his mid 40s or late 40s.
A lot of young surgeons have also passed away. Yeah. So somebody my age group has, at least I know one urologist, one GP, one transplant surgeon, one ENT surgeon. I mean, it's not a joke. Yeah. It's really,
wow. That is quite sad, actually.
Yeah, it's very sad, and they're all in and around my age group. So I'm very happy to pick and choose where I work and how much I work.
Are you staying indoors a lot now?
Yeah, almost nonstop. And I'm most of my work has now gone online. Like just before I started this webinar, I did a teleconsult with an 80-year-old guy who had never done WhatsApp video in his life.
Okay.
So this was the first time ever he did a WhatsApp video, and he said, "You've opened me to a wonderful world."
Excellent. Excellent, sir. Well done.
And I said, "Yeah, please do." I got another one scheduled for 3:30 this afternoon. So,
like I mentioned, listening to your talk, clearly you're pioneering it, and you're taking the step like leaps ahead of even the younger guys. It's I think it's amazing what you're doing, and it's a good footstep to follow. Actually,
every day is a learning experience, Harish.
Yeah.
Every day something new, something new. I mean, on the computer, sitting on the computer, every day there's one new trick you learn. So
yes.
I'm telling you, it's just amazing. What a journey these 30 days have been. Amazing. I am completely a changed person.
Excellent.
I haven't even sat on the video editing suite because there's no time.
Right. Okay.
Okay, so the time is still 1 more minute, so we'll just wait.
Okay, you can see my screen?
Yeah, I can see your screen beautifully.
No problem, right?
Yeah, absolutely.
Okay.
I just want to see if Sham has joined us. Sham Kolvikar is one of our senior cardiothoracic surgeons, and he's an expert on chest wall.
Oh, wonderful.
If he joins us, I can make him a panelist.
Sure. I'm going to focus on just the rib fractures, but not the chest wall.
Yeah, sure. That's all right. But Sham wanted to attend this talk. He loves
perfect.
He does a lot of pectus work, and he's one of, Sham Kolvikar is one of the renowned figures in the world in pectus surgery.
Has he
So,
done a talk on practice already? Have I missed it?
yeah, he did a talk yesterday.
But you have it on
Yeah,
YouTube,
but
right?
it's
So
there
I'll
on our
look it up.
group. Harish
Yeah.
is there on our group. He's done the talk with us before, and the
Okay.
video is there. He's an amazing guy, and he's got amazing concept of practice. Okay, ladies and gentlemen, the time is 12 o'clock midday London time. It's really an honor and a privilege today to invite a very dear friend of mine who is a consultant thoracic surgeon in the National University Hospital, Singapore. And he does a lot of minimally invasive thoracic surgery, and off late has been doing, good numbers of chest wall resections and things. And we've had his lecture on chest wall surgery last year. And this year, we are very fortunate that he's picked up a very hot topic. It is a new topic. It is a different approach to management of rib fractures. And I'm pretty certain at the end of the talk, we will have a lot of question and answers. Because this is a webinar, please type in your questions on the Q&A. And so Dr. Harish Mithiran, thank you very much for joining our thoracic gurus. You are one of the youngest gurus amongst the lot at the moment. And it's such an honor to be with you. Thanks, Harish.
Thank you, Dr. Khan. It's a real honor to be invited to talk once again here. And you know, I'm a big fan of yours, listening to your webinars too. So every time you're on at 1 in the morning here, I'm up listening to it. So thank you for inviting me to talk. So my focus actually of this discussion will be on rib fractures. And I'm going to go more on the clinical aspect of things instead of the more theoretical aspect. And so we start off with, why do we want to fix it? Who are we going to fix, and when do we want to operate? So we understand the anatomy of our chest wall. We have our rib cage, our diaphragm, our lungs, the sternum, the clavicle, and the supporting accessory muscles. And so just like when we breathe, when the diaphragm contracts, the intercostal muscles contract, and the chest, the ribs expand and get pulled out, and that creates a negative pressure that draws air into the lungs, and that allows for inspiration. So we want to have a very nice chest wall that's very intact. But the issue is that if this is broken, like this CT scan or 3D recon over here, where you can see there's multiple fractured ribs. Now what happens is that you lose that motion of that bucket handle motion. And here's another example of a severe case of what we had, a degloving injury of the chest. Sorry, let me turn off the volume. And if you do not do something for this patient, you'll never get him off the ventilator. This is a young 28-year-old male who was on his motorbike, driving very fast, a speed bike, and he skidded and he got a degloving injury of the thoracic of the chest. So I think there are many people who've classified fractures. I think one of the best and the easiest way is illustrated is by Dr. Netter. And he divided fractures from his drawings into just a simple and a complicated fracture. The simple fractures are basically, it can be a transverse fracture, an oblique fracture, an overriding rib fracture, but mainly they're all single fractures and involves only one rib. And of course, you can get complicated fractures, and complicated can involve multiple rib fractures, flail fractures, when the fractures are infiltrating into the lung or have traumatized the pleura, causing a pneumothorax, causing lung contusion, or any damage with a hemothorax. So this is one way to classify. It can be a simple or complicated. So the pathophysio people generally started looking at rib fracture fixation because it's not about just normal simple fractures, but mainly about the complicated ones that you get something called flail chest. So flail chest basically is when 3 or more ribs are fractured in 2 or more places in a row. And this leads to basically what happens is you get loss of that bucket handle motion of your chest, and it leads to something called paradoxical movement. So every time you take a deep breath in, the chest wall sinks in, that reduces your lung volumes, and you get less oxygenation in your body. And what happens is when you exhale out, it moves the opposite direction. And so you lose the respiratory mechanics over here. So looking back, I looked up, preparing for this talk, I looked up the history of rib fracture fixation. And if there's a book on rib fracture management, and it's brilliant. They have lots of history and about how rib fracture used to be managed in India back in 100, 200 years ago, in Islam, in the Egyptian time. But I'm just going to focus on what we have right now in the sense of published data. And Jaslow in 1949 published his first paper on how he managed a flail chest. And what he did was he took a hanger and drilled a hole into the sternum and just hung over this weight over here and just kept the patient stable in bed for about 3 to 4 weeks. And then eventually he could come off. This then inspired Heroy and published this in 1951, where he put a bullet's forceps around the rib and held the rib up to prevent the flail segment from collapsing. And the patient again was immobilized and kept in bed for many weeks before he could finally mobilize and walk away. The drinker respirator, this was very big during times of polio, and the patients actually were kept inside this negative pressure chamber, and it kept the chest expanded. And as I was doing this research, having said that, now during COVID-19 time, people are actually looking into this same concept again, because we're running out of ventilators, but actually use this kind of the same drinker respirator for patients who have severe respiratory depression from this COVID virus, and they put them in this very compact negative pressure chamber here to help assist with the breathing. So moving on, in 1963, this was inspired over the toilet plunger. They designed this Cape Town limbet. Again, it put suction onto the chest and pulled the chest up. But the first one was Constantine, who actually designed this first mobile rib fixation device, where he actually just used literally a device like this and tucked it under into the pleural space or subpleural space. And he then tightened the screws and traction and boarded it to a board. And this allowed patients to actually start mobilizing, even when they had a flail segment. So this was the first probably documented mobile rib fixation medical device actually. So what's out there actually for rib fractures now, and why have we stopped managing them? So the issue basically is that probably until the 2000s, the current standard of management for flail chest basically was just mechanical ventilation when it was required, and give adequate analgesia, and then they should recover. And surgical management was not routine. Why? Because firstly, many surgeons were not aware of what was actually out there, what evidence was out there. They were not sure what operation to perform, to put wires, to put plates, and they didn't even know what prosthesis to use. And on top of that, in the early 2000s, there's very few prostheses in the market at that time. So why do we operate on these patients now? And what suddenly they say, okay, why should we fix rib fractures? I mean, people have not been doing it for many years. Why should we go ahead? So the first thing I want to bring your view is actually to the association of morbidity and mortality with rib fractures. And this paper was published in Trauma in 2003. And the purpose of the study basically was to just look at age and mainly focus on elderly patients who are admitted just purely with rib fractures after blunt trauma. And they had a look at a retrospective cohort of about 4,300 patients. 10% of them had rib fractures, and those more than 65 was about 113 patients. And when they compared these group of more than 65 years old, they noted that this particular group of patients had a higher risk of increased pneumonia and length of hospital stay. Their mortality rate was higher, of 19.5% if you're above 65 compared to 9.3% if you're under 65. And if you're more than 65 years old, you had 5 times the higher death rate than if you were under 65 if you had rib fractures. And you can see here they plotted a graph, and you can show that depending on the number of rib fractures, your percentage of dying was a lot higher. Again, another one that looked even a bigger group of patients published in Surgery in 2005 looked at 731,000 over patients in America, and that they isolated again roughly about 10% of them, 64,000 of them with isolated rib fractures. And if you look at this graphs over here, As the amount of rib fractures increased, the risk of getting a pneumonia and ARDS increased. As the number of rib fractures increased, the mortality increased quite a lot. I mean, if you have more than 8, you had almost a 34% chance of dying. And if you had increased more ribs that were broken, the risk of getting pneumothorax, aspiration, and empyema were a lot higher. I mean, of course, you can explain because the more ribs that were fractured, it would have been a more greater impact of injury or blunt trauma. But this is how we look at it. So whatever it is, the person who's coming with more rib fractures is a high association of dying and morbidity. So, you know, we should do something about it. We can't just let it be. So what's out there? So, you know, there were some papers that came out, and I think the one that came out, probably I can pull back the earliest paper, or sorry, the earliest latest paper was 2001, where Tanaka published, he looked at just conservative management of patients, and he had about 59 patients in his hospital which had flailed chest. But this group was, you know, he published the paper in 2001, and he pulled out data from 1985 to 1995. And he divided them into two groups. The first group in 1985 to 1989 was Group A. And then he mentioned after 1989 to 1995, they changed their practice of managing flailed chests. And they started using pressure support on spontaneous breathing for these patients, or they gave them CPAP via mask, and they made sure they had some respiratory, physiotherapy for the patients. And what you can see is over here between the patients who received all that extra treatment versus, sorry, extra treatment here versus no extra treatment, the mortality rate actually is almost double that. And also the risk of getting an infection was so high, and atelectasis. So, but whatever it is with conservative management, even with all the physiotherapy and CPAP and stuff, the risk of dying was 25 to 51%. And the risk of getting pneumonia was 27 to almost 70%. So after that, what happens is people started developing new products out there and new medical devices and implants. And so they started looking at comparing. Now they wanted to probably promote it. They wanted to say, hey, it's getting better. So the first probably retrospective study that I could find was from the Journal of Thoracic and Cardiovascular Surgery 995. Dr. Zahur Amit from Abu Dhabi, he looked at a retrospective review. He looked at 64 patients with a flail, and he fixed 26 of them with a K-wire, and 34 of them were just doing the normal way with endotracheal intubation and positive pressure ventilation. So these were the K-wires on his X-ray that he showed in his journal. And what he found basically was that the patients who had the internal fixations with K-wire, 80% were weaned off the ventilator in an average of 1.3 days. Sorry, in about 1.3 days. The average of them was about 3.9 days versus 15 days for the conservative group. And in the internal fixation group, only 3 of them actually required a trachea versus the other group, the conservative group, was almost about 37%. And then he looked at the other components of things. Chest infection was better in the guys who had the K-wires. Septicemia was much lower, no barotrauma. Mortality rate, again, significantly different here. And the average ICU length of stay was 9 days to 21 days. So moving on then, trauma in 2002 published, again, Dr. Tanaka from Japan. He then did a prospective study, basically, and he looked at 37 patients who had flail who required mechanical ventilation. And he actually matched them quite exactly. So all patients had exactly the same respiratory management. They had endotracheal tube intubation. They were mechanically ventilated. They had epidural, analgesia. Everything was match for match. The only difference is after 5 days of the injury, one group was surgically stabilized with Judet struts, and another group was just kept on the internal pneumatic stabilization. After that, everything else was identical again. So if you look at this data, these demographics here, the number of fractures are roughly similar, the age is roughly similar, the ISS is roughly similar. And what he found out was that the surgical group, the percentage of pneumonia was much more higher in the internal, those with a ventilator. The length of the ventilation was much higher. And also the length of ICU stay was much higher. And the need for tracheostomy also was much higher. All right, so this is a prospective study. Then he looked at them 12 months later. And again, he did a questionnaire for them. They looked at chest tightness, chest pain, thoracic cage pain, and dyspnea. And if you look at this is the ventilated group and this is the surgical group. And you can see there's a big difference. And then we looked at return to work. So the black line is the return to work. So after 12 months, 16 of 18 out of them returned to work versus only 12 out of 19 of them who returned to work in the ventilated group. This spirometer also, of course, that also improved in the surgical arm. All right. Another prospective study here was published in ICVTS in 2005. Again, they had 40 patients, but this group ended up actually had strapping and packing, and they strapped the chest around with elastoplast, and they kept that for 7 to 10 days, whereas the surgical group went in and they fixed the patient with either K-wires or stainless steel wires, or both. And again, the numbers were quite matched quite evenly. And again, I want to point down to you here that the mean duration of mechanical ventilation for the conservative group was 12 days, surgical group was 2 days. ICU stays were all comparatively and all statistically significant. The last one, and probably this is the last prospective study that I could find, actually was Silvana Morasco. She's very well known for rib fixation in the circles, and she's from Australia, and she did a prospective study, and from her data, basically, she found that, of course, the ICU stay was a lot shorter. They required lesser invasive ventilation after extubation, okay? And but one thing she told me that when I spoke about this paper, she said that, you know, the one thing she was looking forward to was to show the rest spirometer would be better. But she said actually the quality of life and the spirometer was roughly about the same in these two groups in her study. So after looking at these studies, I just went and said, okay, let's look at the whole big picture, the meta-analysis of everything. Let's see what people have gathered. So published in Journal of American College of Surgeons 2013, they looked at 11 manuscripts. They got about 753 patients in total. But just to run down the same thing over and over, ventilator stays were better with a odds ratio of the odds of developing pneumonia was a lot better, decreased ICU days, mortality, septicemia, tracheostomy, and chest deformity. And then another meta-analysis, but they only looked at those 3 randomized control studies. And again, we come down to the same conclusion again. So what's happening right now is in Netherlands, Dr. Mike Bellman and his team is actually doing a multi-center prospective study, and they're going to actually really look at comparing fracture, fail and multiple fracture with non-operative management, and we'll see what his results are. Finally, you know, after all these papers have come out in 2010, the NICE guidelines finally said, okay, we should come to a consensus of what it is. But they never actually spelled out actually who to fix, who not to fix. But basically, they feel that they said that with the current evidence, fixation with a flailed chest, fixation of flailed chest patients can be offered routinely, provided the patient understands the procedure and agrees, and the results in the procedure should be monitored. So I think we're still waiting out there for a proper clear-cut guideline. So in conclusion, most literature out there tells us why fix ribs if they're broken, and especially with the flails, is because you reduce the ICU stay, you reduce the hospital stay, you reduce the risk of pneumonia, you get an earlier return to work, and you have less pain. So after we've seen the evidence, now we go, okay, who do we fix then? Okay, should we just go fix everybody with a rib fracture? Okay, who do we fix, and do we fix them all? So a lot of times actually we encounter patients like this. Yeah, they have multiple rib fractures, but they are non-displaced, non-broken fractures. Do we need to go fix them? No. You probably do more harm than to fix these kind of patients. But patients you want to look at are patients like this, with severely displaced rib fractures over here, or patients with flail fractures. Okay, so the 2 main groups of patients we need to look at is the first group who have a flailed chest, okay, which is defined as a chest injury with 3 or more consecutive broken ribs on two ribs. And the second group basically are patients with multiple rib fractures with no flail. If you want to further break it down into their indications, I think you can look at it from 4 main areas. The first thing you want to look at is the anatomical consideration. So if they are flail, the evidence and the indication over there is actually very, very strong. Number 2, patients with chest wall deformities, severely multiple rib fractures are broken in. And the issue with them is actually when the chest forms or stove chest deformities, it dives in. Definitely without a doubt, like I show you the photo of the rib cage and a normal person, you lose that bucket-handed motion, you lose the volume that the lung can expand out. So the patient with multiple rib fractures with a chest wall deformity is something to consider. Patients with non-union ribs that are not healing after 3 months, or chronic malunion where they heal in a different position like that, what happens is this bone will start to impinge on the intercostal muscles and all that and cause severe chronic pain around them. It also then, what happens is you get this bridging between the intercostal spaces because the bone doesn't know where to join. It just open up, it may join to the rib above, it may join to the rib below. And that creates like a whole big, like a cement block of actually just rib there. And that can be an issue. Non-union is important because they get this clicking thing and then they get splinting of the intercostals. And I think that's one of those patients that you should look at. Palmy herniation, should you not, okay. Open rib fractures is something we can discuss. And of course, depends on the number of rib fractures or number of rib displacements. Another thing we should consider actually is the physiological portion of it, is when patients either fail to wean from the ventilator. This is a very strong indication, I think. And then a little bit something to debate about is patients with poor pulmonary function. You can improve their pulmonary function better if they had multiple fractures and you fix them. Quality of life is important, especially when it comes to pain. We know clearly that it actually can help to reduce the long-term disability and pain. And of course, on the way out, thoracotomy. This is something that we practice all the time. We make a cut, we go in for hemothorax. If you're not doing it by vets, you do a thoracotomy and you find that if multiple rib fractures on your way out, you might as well fix the ribs on your way out. So in general, in my practice today, what we do is we look at patients between 18 to 80 years old. They come under our criteria. Whoever has a flail chest, who have failed medical management, ventilator and non-invasive ventilation, will fix them. Patients who have organ impairment, the rib is broken and pierced into the lung and is causing a severe pneumothorax, we'll fix them. Severe displacement found during thoracotomy or on the way out thoracotomy, like I mentioned to you, and symptomatic non-union of stove chest deformities. We also look at patients who have more than 3 ribs flail not requiring mechanical ventilation, patients with more than 3 ribs with severely displaced fractures, or basically more than 3 ribs who have actually failed pain management. And so usually these kind of patients, I look at them, I give them about 7 to 10 days. And if they still have a lot of pain on breathing and moving, then generally we will then fix them. And if you're going to fix, which ribs do you fix? So usually 1, 2, 3 is firstly very difficult to get. Number 2, they don't play a big role in the breathing mechanics, but the rest of your ribs 4 to 9 you should fix, and the floating ribs you don't need to fix them. So relative contraindications, people always talk about lung contusions, and lung contusions are something that you have to look really, really hard into, because if you even do fix a rib with a patient with severe lung contusion, can you actually even still get him off the ventilator? So this is a gray area, and people always debate about this. And again, contaminated feel, I think this is I put a question mark there because I feel that is something that we clearly should talk about, because even in orthopedic surgery, they will clean and then they will implant. So coming back to it again, like I mentioned to you, if you get the fractured ribs, who should you fix? The first thing you should look at actually is the CT scan. Don't look at a 3D recon, but look at the CT scan per se. Now, patients who have bicortical or 2 table break fractures are probably the patients you want to actually address. The patients who just have a fracture, a simple fracture, and is not displaced or mildly displaced, you don't need to fix those guys. But the patients who have 2 table break that's broken out a little bit, these are the things that can are probably people you need to look at to actually fix. The reason is, number 1, it heals in not a proper union. And the second thing is, say you don't fix them, and we've encountered a few of these patients, is that you discharge them home, they're well, and what happens is as their muscles get stronger and they get more agility, it actually pulls the ribs apart more. and it displaces the fracture further, and they come back a week later with severe pain. Who do we exclude from our criteria completely is I generally don't fix patients who are pregnant because of the GA risk, age, old people, patients who have severe head injury, spinal injury, who are severely have a lot of medical problems, coagulopathy, patients in ARDS, very septic patients. And of course, what's important is that if they don't expect to survive the follow-up period, I don't think then you should repair them. So how do we do it? And the first thing we do basically is that we get, like any before anything in surgery, we take a clinical history, we do a thorough examination. We get a chest X-ray. We need, part of our workup is a CT thorax with a 3D recon. And of course, in the operating theater, we should actually have an ultrasound present. So an X-ray, you can see here, there's multiple rib fractures present over here. And the CT scan, like I mentioned to you, 2 table breaks is something you should consider. And this is severe, like this is a very bad traumatic where the rib is actually going in and piercing and traumatizing the lung. So these are the patients who actually will benefit the most from these conditions, from these rib fractures to fix them. So when you get a 3D recon, the rib cage, what is important that actually you communicate with your radiographers when they do the recon. So you can get a 3D recon like this with the scapula in place, but if you get a lot of subscapular fractures, then you want to get them to eliminate the scapular portion of it and get you a recon like this. So this will be better for you to plan your surgery if you want to. In the operating theater, you put the patient in the GA. Can't do non-intubated here. You can try, but I wouldn't recommend it. Whether you should use a double lumen tube is the question, because if you feel that there is hemothorax present and they need to have a washout of the chest, so it might be a good option to put a double lumen tube in, collapse the lung, do a thorough washout of the hemithorax, and then fix the ribs. CT scans are important. Like I said, your 3D recon, you should print out the 3D recon and put it, and so you can understand exactly which ribs you're going to fix and mark it down, and I'll show it to you later. And like I mentioned, you need an ultrasound. So the reason for the ultrasound is that ultrasound is really good to localize the rib fractures, and this can actually plan your surgery, and you can mark it down with an X exactly where it is, and you can plan your incisions then that way. All right, so this is what I have. You can either have this, or I usually nowadays just print out the 3D recon, and I label it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and I put an X, and for simple fractures, or an X for comminuted fractures, and I just mark it that way. And I draw out the scapula on the side there. All right. So now that we're ready to go, we found out with patients on table. Now we got to find out, okay, what's out there in the market? What can we use to fix the ribs? So I don't have this product here, but in the US they have this thing called RibLock. Juliet struts are over there. I think the 4 main things are the RibLock, the Juliet struts, the KLS Martin system, the Stratos and Strakos. Strakos is for rib fractures. And what I use here in Singapore is the Matrix Rib system. So once you pick your set and you know what to do, then you prepare for surgery. You want to position the patient, and then you want to have approach. So with rib fracture fixation, it's actually there are a few people who are doing some sort of minimally invasive surgery for it, but most of us, when you want to fix with multiple rib fractures, you're going to make big cuts and big incisions over here. So your positioning basically the patient can either be supine, and in supine, then it's mainly for anterior or anterolateral fractures. You can turn the patient in a normal decubitus position, whereas mainly you can address the lateral and posterior fractures. And you can put the patient prone, where you can address the posterior and the subscapular fractures. So our landmarks journey, from my point of view, whether it's anterior or lateral or posterior, is basically, if it's lateral, is your scapular point, anterior will be your subxiphoid in your sternum, and posteriorly will be your spinous process. Very important to mark that out. So there are 5 main, there are many types of incisions you can make, but in general, a broad picture is an inframammary incision, a lateral incision, a posterior paramedial incision. This is done in the prone position, or vertical, a straight down cut. So inframemory position is like incision is like this, is right under the memory, and this you can address a few of the anterior fractures, and usually it's like number 4, 5, 6, and maybe even 7. Infrapectoral is like your hemi-clamshell position. I want to thank Dr. Mike Bellman to give me these photos. He did an extensive cadaveric dissection to show you how to expose the ribs, and this is one very clear view you can see. And I've never done this incision for any anterior fractures yet, but he's done one on the cadaver, and he's shown you that you can actually expose thoroughly everything. You can lift the pec major, the pec minor, and you can expose 2, 3, 4, 5, and even if you retract under here, you probably can get to the 6th rib. Posterior lateral incision, I think we're all very comfortable with this incision. And this incision gives us a really great view of literally number 3 to probably 8th rib. And it works very well for the posterior fractures near the spinous, near the transverse process, and also the lateral area. So this gives you a really, really good view of everything. Over here you can see here that the erector spinae muscle is around here, and we can really place all the plates, and posterior and lateral fractures can be addressed very well here. Another one with a posterior lateral, posterior or semi-lateral thoracotomy going a bit posterior, and it's generally to address the lateral root fractures over here. Okay. The posterior paramedian incision is very good for very posterior fractures. And you place the patient in a prone position, and you make a vertical cut down there, and this can actually then expose all the posterior fractures. So here's one. I think this is the spinous process over here. And what you do is you retract, you either dissect, or you can even retract the erector spinae muscle, and you can expose the posterior ribs very well over here, and you can implant the plates accordingly. There's another incision. It's a paramedian incision. All right. Especially over here, you can see the posterior fracture, so you can address it by making a vertical paramedian incision down there. And of course, with sometimes a lot of very lateral fractures, you may just get it all in a row. This is your vertical approach. You can just make one long cut down here, and this you can then expose, and you can see all the multiple ribs over there by even splitting just the serratus muscles to get to the fractured ribs. So as we progressed, when I went for one of the courses, we were giving a talk, one of the lecturers over there said, oh, he started using the soft tissue retractor, or the Lexus retractor. So his incisions were smaller, and you put the soft tissue retractor, you can expose, and you can actually get 3 ribs, especially if they're in a row. So this is like one of the, just turn this volume off. And here we go, we can see we put the soft tissue retractor in. And I think this patient had 3 or 4 rib fractures, and we decided to make multiple small incisions on the skin. And we can see here, these are the fractures being exposed. And the final repair on this side of it, you can see here that it's got a good exposure. So this way it eliminates all the tissue, all your lat dorsi and your serratus muscles all getting in your way while you're trying to dissect. It just clears the environment thoroughly. And here we made a vertical incision. It's multiple ribs. I think even addressed maybe the 3rd or the 4th rib here. So it's 1, 2, 3, 4, 5, 6 ribs, and you make a long incision. And really, maybe the incisions may be about maybe 8 to 10 centimeters long, but you're addressing a lot of ribs that way. So, you know, as we're going and trying to make the cut smaller and smaller and trying to fix the ribs, Synthes has come up with what we call the MIPO system, or minimally invasive osteosynthesis system. And through this incision over here, you can then tackle the more distal fractured ribs by exposing them and using this drill system and screw system. It just takes a little bit of practice, but I think if you do maybe 2 or 3, you'll get the hang of it. And I think generally, once you become an expert using the rib fracture system, you will be able to do this very easily. A lot of people are trying out new things, and I think innovation is the key. And we have to applaud these people. It's very tough what they're doing, but at least the ability for them to try to innovate and do something new, I think is amazing. So this author over here presented a novel way to do reflexor fixation, extrathoracic. So what he did was he made 2 or 3 small cuts on the skin. He then freed the muscles off the ribs, and then he put the scope through here, and extrathoracically he fixed the ribs. I must say it's very challenging, but it's great that they're doing this. You know, and then another case report here from the US also, where they are doing the rib fixation via VATS. And you can see here, usually the screws be pointing inwards. Here the screws are pointing outwards, and I think it's a great job. And I think this is the future, that people are going to invent new things and make it better and easier to use. So once you fix the ribs, what do we do? You know, post-op management. So unless the flaps are very big and you make very big incisions, you can place Redivac drains, but I usually hardly do that nowadays. If you enter into the hemithorax, please put in a chest tube. Into the pleural space, sorry, please put a chest tube. And I generally start using the on-cue pump or the intercostal nerve block. That's a continuous infusion that lasts between 3 to 5 days. So I place that for all my rib fracture patients. Oral analgesia, and I make sure they get good spirometer, and they do that, and they start ambulating very quickly. We've designed a package, analgesia package for our patients. And most of them, basically, when they come in with rib fractures, we give them IV paracetamol. If that doesn't work, we go higher to naproxen, we can go to morphine, and then we always add omeprazole, and we give them ondansetron along with it. And those who have NSAID allergy, we give them tramadol, and then of course we're on impairment, we cut the dose down. So rib fracture is great, but with anything we do, we can develop complications. Most of the complications, you can see the highest amount would be these 2 areas here, which is wound infection and chest tightness. There's always a risk of hardware infection, and that becomes a real problem. Empyema, of course, if you have a hemothorax, and this is why we recommend this, if you have a hemothorax and you're going to go in to fix the ribs, I think it's good to just go in there and wash out the chest too. This reduces your risk of getting an empyema. And I usually cover my patients with antibiotics post-op for at least 5 days. Chronic pain, and of course hardware migration and hardware failure is the main things. So hardware complications can occur, basically plate fracture, plate dislocation, or even the screw can get loose. Now, I've had a few complications, and we had to implant, but most of my complications actually came from when we did it for chest wall reconstruction. And so I will talk about the Stratos system, and this is a paper published where they used the Stratos system to do pectus repair. And they noted that in their patients, the Stratos bar started failing between 10 months to 2.5 months. And what happened? They got loosening fractures and loosening with fractures. So this is the Stratos bar for pectus patients, and you can see what happens is the bar's fractured over here. And this again explains the bucket handle movement. These bars are not meant to just move free like this, and eventually, because of the tensile load, the bending load, eventually they snap and they break. They get micro cracks and eventually they break. The Judet struts also had the same issue over here. And Dr. Kelvin Ng from Hong Kong reported his patient who had the matrix strip and who had he did a single fracture rib fixation. And after a few months, the patient came in. It was a really incidental finding, and decided to explant the fractured plate. On my side, basically, I've had a few when doing chest wall reconstruction, which is screw loosening. And you see, screw loosening can basically happen in elderly patients with osteoporotic ribs. And the main thing basically is the mismatch of the screw length and the rib. So you actually, either it's too short or way too long. Way too long usually doesn't come out, but it starts to impinge on the underlying structure, which I'll show you a complication of that. But if it's too short, then it can slip out because there's no double, it doesn't go through both the tables. The other thing what people do is also something when they're drilling the hole to put the screw in, what happens is they double tap or they drill 2 times and it destroys the bone threads around there. Then the matrix strip has a locking screw. So sometimes when you come in at a different angle, it doesn't lock properly. So people make that, and it's, or you can, sometimes people feel that it's not very good. they're screwing in, they tell, okay, it's locked in, but actually it's not sitting on the bone, but it's actually sitting on the edge of the bone or sitting on the muscle. And so people make that mistake, and that's when the screw can get loose. So here's a patient of mine with a chest wall recon, and you can see here this screw, this displaced, and I try to get away with it, and I should have put 2 more x-rays because I decided to fold this, and this screw kept on migrating. Eventually it migrated to the tip of the scapula, so it was great. I managed to get it out very easily. But if you have a screw, the problem is that when the screw starts moving around in the patient, they actually can get pain, especially if it's under the scapula. And this patient always had this weird sensation, and eventually she said, look, just take it out. And that's what we did. We went ahead and we took it out. But we were just lucky. We waited for it to actually come to the tip of the scapula. That journey doesn't happen. But another patient I want to show you is a reconstruction of using matrix rip in a patient with a breast cancer. And it's important to get good muscle coverage over these plates. And for rib fractures, is not so bad because generally they are they are generally healthy patients who get into road traffic accidents and they don't have any cancer, and you're not resecting chest wall per se. So there's lots of muscle and stuff over it. But in this patient particularly, she had a chest wall resection, reconstruction, then given RT. And subsequently, what happens is, if you can see, we did the surgery in June, July, August, October. You can see they're starting to get some skin excoriation here, and the skin is thinning over there. And eventually, you can see the plate popped up, or the skin came out. But she was very, very well. We went there, we just took her in, we just cut the plate because all the tissue under there, because we did place an underlying Prolene mesh for this patient, so the tissue underneath her to harden really, so it wasn't a problem. Unfortunately, 1 year later, again, she started getting the other one, so we cut the other plate again, and she's been well since, so we got away with that. Another patient, what happened over here is if you don't measure the screws properly, and you can see here the screws were longer than normal. He had multiple rib fractures, but this is, I think, at level 8 and 9. And he got a subphrenic collection because I think it was irritating on the liver. We were a bit worried because we thought this is impinging into the liver, but when we actually went in for surgery and we aspirated, it was just fluid. So that causes irritation of the diaphragm, actually, that caused this subphrenic collection. But so this is one reason why you should measure your screws very, very, very thoroughly. So review what we have done, basically, like I mentioned to you, we started this program in 2015. Up to 2017, I took our data. We just did a broad outlook. We had 39 patients in total. 29 were male, and their age was 27 to 77 years old. Generally, they had an RTA road traffic accident, fall from height, kicked by horse, forklift injury, 1 patient. And the average time to surgery was about 5 days, but some was 0 to 16. I generally wait out a little bit for my patients unless they're on a ventilator and need to come off. But I generally wait between 5 days to 1 week and really, really assess them. The initial phase, yes, it was very gung-ho, let's go fix everybody. But after a while, we started noticing that, we wait out. And the patients who actually had multiple fractures with chronic pain, some of them actually became normal, but some really, really need the surgery. So we decided to wait between 5 days to a week before proceeding for operation. So surgery to discharge, our average is about 6 days. Number of patients requiring intubation, 7 patients were intubated with flails. Number of days required to extubate post-operative for these patients was 0 to 2 days. So it's very fast, we got to extubate them. And after we extubate them, only 2 of these patients required NIV, and that was 5 to 6 days. Left-sided fractures, there were about 24 of them, and the right side was 12. The average was about 6 fractures on the left and 7 on the right. And the common ones were 4 to 9 on both sides. So here's the day my medical rep was very happy with me. He had multiple fractures, but these are posterior and lateral fractures. So we literally went in there, we fixed everything, and it was very, very displaced, all of them. That's why we went and did it. Of this group of 36 patients, basically, the readmission was in 3 patients. The one I showed you earlier happened in 2018, so I got to add that. That's 4 now then. But 3 patients, 1 patient had pericardial effusion, and we don't know the cause of this. We just drained it and it was fine. 1 patient came back with pneumonia, and 1 came back with superficial wound infection. Post-op complication, one patient had left subclavian DVT. Again, I think maybe the position of his arm or something happened. We weren't very sure. As for medication, most of them required paracetamol and another analgesia. So usually we cover them with an NSAID. And 6 of them required all 3. We give them Panadol, Arcoxia, Tramadol, and maybe we cover them with some other pain medicine, like maybe a ketoprofen patch or something. But most of them actually, within 2 weeks, Jenny, are off all the pain medicine and they're quite well. So case study, what I wanted to show you is just 2 main cases. And this is one case that had a fracture. Came in and she had a fall. But when we didn't, she had very bad pain in the back. When we did an x-ray, everything was clear and we advised the patient and said, okay, go home if you find nothing wrong with you. She came back 1 week later with severe pain, and this time she didn't do anything. And you can see here, these are new fractures that appeared. So what we believe is that she actually had the fractures and it wasn't displaced at the time. But a week later, after she went back to some normal activity and tried to do some stuff, because of the contraction of the muscles around the back, it kind of pulled the fractures apart that caused the fractures to break. And here they are, the fractures a week later. And we did a CT scan and a 3D recon for her, and these are the fractures on the right side. And we went in and posterior fractures, and we went in and we just fixed it because we felt her pain was so immense, and so she passed the test of waiting it out. And back to my degloving injury patient that I showed you on the beginning. So you can see here, he was riding a superbike, but without all the superbike gear. And so when he skidded and fell, he was just a t-shirt, it just ripped right off. And if you can see here, the abrasion over the skin, and when we lifted it up, all the muscle under here was just torn. And I don't know why he had a hole here. It's like an exit entry. I don't know if a rock went in and came out the other side, but every other muscle under here was all ripped. So we decided to make the cut bigger, and we washed out the wound. This is his x-ray, and this is his 3D recon. You can see here all these multiple fractured ribs and displaced ribs. And back to this video. So what we did was we opened up everything, we washed everything out thoroughly, and then we packed the wound and we vac dressed the wound for about 2 days. We came back again the second day, we washed it out again, and on the third day we felt that it was all very clean. And so literally we had to do a partial chest wall reconstruction, I would say, for trauma, because there are a lot of missing bits of rib and stuff. So we washed out his hemithorax. We then plated him with all these rib plates. As you can see, there's some plates that are missing bone. And our plastic surgeons reconstructed the muscle flaps. And this was him post-op. I mean, imagine a patient with this kind of fractures. He was actually surprisingly extubated the next day after we fixed the ribs. And the plastic surgeons did a good job for him, and he actually got discharged a week after his big trauma. And this is his X-ray after maybe about 3 months. So eventually, I think not every patient should be fixed. I think this is very clear. I think flail patients should be patients you all should target, and you will really benefit them over there. As for multiple rib fractures, think of patients who are displaced fractures, and you should consider fixing them. So take-home message for me is, for rib fixation, basically it reduces ICU stay, reduces hospital stay, reduces the risk of pneumonia, early return to work, and less pain. And the recommended group to fix basically is actually patients with more than 3 flail chest, more than 3 ribs fracture with flail, symptomatic non-union or stove chest deformities, patients with severe displacement found on the way out thoracotomy, and consider these patients with multiple rib fractures. So, and again, if you're going to fix it, fix rib number 4 to 9. I think going higher doesn't play very much role in the ventilation. So I always like to put up this thing of where we were when we talk about patients with flail, and you just ventilate them and they have a long ICU stay, and then you fix the ribs. They can come off the ventilator faster and go. It's this classical video. It's all on YouTube. It's on LinkedIn, about Formula One teams in 1981 and where we are in 2019. And this is a classical pit stop and just look at it, and you can tell if you count by seconds, 1, 2, 3, 4 seconds they're off. And if you look at 1981 and you just keep counting, you'll probably reach up to about 29 seconds before they actually let him go. All right, so we need to always innovate. We always need to do things, and we must try new things and look at the evidence before going ahead with it. So with that, thank you.
Thank you. Thank you, Harish. What a great talk. I really enjoyed that. It was amazing. But obviously a talk like this will bring up a lot of questions. And I think you've got to be ready to take the questions and the issues that come along with it. Is that okay, Harish?
Sure, that's good.
Right. So first I'm going to put through the audience question, and then I'll ask you some questions, which we'll just discuss the strategies and things that we've got. So I've got Sameer Bhatia, senior cardiothoracic surgeon, asking 2 questions. Do you place any subcutaneous drains post-fixation, like a Belavac drain? And second question is, what do you do for DVT prophylaxis?
Okay, like I mentioned earlier, unless it's very large flaps, I generally would put, I use a Radivac drain for these patients. And so it all depends on the size and the cut of the incision, and if I feel it's very oozy. Most of the time, like I mentioned to you, we're not cutting muscle. I mean, we're cutting the muscle, but we're reconstructing them very well. We're not removing any muscle tissue. And so we do a thorough washout, and we feel it's adequate compaction. If we feel it's not good enough and we feel it's very oozy, we put a Radivac drain. If not, we just close and we put what's this called? Pressure dressing over it. As for DVT prophylaxis, I actually don't use it at all. So because these patients are ambulating after day 1, day 2, post-op. So our basic thing, what we do is when they go back to the general ward, it's immediately next day sit out a bit on the chair. And then with the physio after their lunch in the afternoon, get up and ambulate. And so we ensure that, so very rarely, of course, there are some special circumstances, but generally I don't use them for simple, straightforward fractures.
But I'm assuming intraoperatively you use the DVT pump and put them on dead stockings and things like that.
So that's okay. So intraoperatively standard practice, yes, there is the DVT pump. But as for post-op, there's no IV prophylaxis. So there's no Clexane or anything like that.
Okay, good, excellent. So that's very clear concept. Now, I just want to clarify this for the audience. Again, these are sort of the points that are picked up from your talk. So we fix ribs when you've got a flail fracture, a flail segment. Mm-hmm. Actually, before that, the first indicator to fix rib is inability to wean off ventilator.
Yep.
Second would be when you've got a flail segment. And the third would be non-resolving intense pain a week or 10 days after the fractures, after the accident. You agree with these 3? And these are the main real indications for rib fixation. Now, there is a current trend since this NICE guidelines came in, okay, the 2010. There's a whole bunch of young surgeons out there who do not understand health economics and who do not understand the concept of the cost involved in an operation versus conservative management. And a whole bunch of them are publishing, series of 15, series of 10, series of 14 of fixing simple fracture ribs. Yeah. I mean, I worked for, 2010 to 2017, I worked in Medanta. And for the first 5 years, I was on call every night. And Medanta is next to a highway, which is doesn't have a big hospital, 300 miles north and 300 miles south. So every night we would get a road traffic accident. You know how the driving in India is.
Yeah.
And out of that total, I would operate on rib fractures maybe 2 or 3 in a year. So really, you've got to be very selective about the indication for doing fixation of rib fractures. And the three that you mentioned are crucial.
Yeah.
The guys who are fixing every single rib fracture that they see are actually not doing the specialty any favors. I think they're doing a disfavor to the specialty, because a lot of people are questioning, is this industry driven? So
Yes,
I want to ask you this question: is this industry driven?
So I think it's absolutely correct. Now we see on average maybe about 100 to about 150 rib fractures a year in my hospital, and I fix about 10 to 12 a year.
Excellent.
So that's the target. Like I showed you my data for 3 years. I only fixed 37 patients.
Sure.
So the reason for this is that, yes, there are a lot of young surgeons, and all of us are gung-ho and want to just get our name out there and do things, but you got to, whatever you got to do the best for the patient, not the best for yourself. So I genuinely, and I'm very, very conservative when I fix the ribs, and the GS team is very good. They always call me, even if it's a one rib fracture, they'll call me, hey, Harish, come and see the patient. And so generally we bring the whole thoracic team, and the 3 or 4 ribs that are fractured in a row, the younger residents will say, oh, let's go in and fix it. And I said, patient sitting up and having his lunch and saying, I just have a little bit of pain. Why do you want to go and make a big cut and cause more pain for him? And so I think you have to be very important. You need to say, this patient doesn't require it, and this patient requires it. As for industry driven, I think I wouldn't say it's industry driven. I think industry has given us an avenue for us to treat patients who actually require it. And it's up to us as surgeons to actually decide whether you want to use or abuse the system. So I wouldn't put it to the industry. The industry is actually helping us by designing it and helping us with these patients with flail and severe pain and stuff. So
I have no problems with industry coming up with new technology. I'm all for technology, and I'm a very quick adapter of technology. But I have a problem when there is a push to use devices which are not adding value to the care of the patient. Because I promise you, I've also done an MBA and I understand health economics. And putting in a plate which costs 1,500 pounds, and just when you fix it, you really need to use 4 or 5 plates, and each screw is a few $100s each. It's a very expensive business, and conservative management will give you similar outcomes in non-operative cases. Do you know what I mean? So you've got to think hard before you decide to put in devices. But
absolutely agree with you.
People have to be careful about that. I mean, just to give you an example, that you showed an X-ray of Calvin's patient with 1 plate, and then you've shown me an X-ray with a fracture of that plate. So then you start questioning, why do you need to put 1 plate? If you're going in, you need to put at least 4 or 5 plates.
I have to go in and read his paper again and why the patient was.
I'm not sort of criticizing Calvin. I'm just saying that it is important to ask these questions for the juniors, because we have got youngsters on the group and we need to sort of tell them the real indications for this. The second question I want to ask you is, I saw your pain management package. Excellent. I really thought it is a very well thought out pain management plan. The key thing for these patients is pain management. You agree with that? That is the real thing. The one thing missing from that plan was transdermal patches. I was wondering, why do you not use transdermal patches?
Okay, so when we designed that, we actually didn't actually think that it would benefit the patient a lot. But as we evolved and we started managing the patients more conservatively, more and more patients are actually getting the ketoprofen patch or the NSAID patch, basically that. So definitely, we basically are very new in this, or I've become very new in 2015. I only started. So I completely agree with you. I think we need to update our chart, but individually, the doctors are just prescribing it already.
No, it's an excellent package. I think that is what you need. You need an organized package so that everybody knows what you should give. What is the percentage of use of epidurals in your group of patients?
0%. Why? Because I'm using the on-cue, the intercostal block. So I think you know, I was talking to one of my anesthesiologists, and she's very, very forward thinking. And she says, I think epidural for thoracic surgery may become a thing of the past. Of course, you still need to do it for major chest wall resection and stuff. But as you can see, even when we do a lateral thoracotomy now, we're not doing the big posterior laterals anymore. We're actually just doing the lateral thoracotomies. And on top of that, when we are doing it, we just place this intercostal block, so it kind of serves its purpose. So, you know.
Excellent. Do you send the patients home on on-cue?
No, I take it out before they go.
You take it out, but on-cue has a system where you can actually send them home on on-cue.
Yeah, it comes with a ball and two small things, and you can. But most of my patients get discharged after 4 to 5 days, so we just pull it out on the day of discharge. So,
okay. And another very good thing that you mentioned was the role of ultrasound. Just highlight that again for us.
Okay, so what we do is after we position the patient, so if we're having a lateral fractures, for instance, and you put them in a decubitus patient, some people use their palpation method. They palpate and they feel for the fractured ribs. But what I found that sometimes you're palpating the above rib will be further, lower and stuff. So what we did was we used the ultrasound to pinpoint the exact location of the fracture. And it's very easy to do. All I did was I just went to my radiologist and asked him, hey, how do you scan ribs? And he went, just put the probe here and you can see. And then immediately I went to theater and I put the probe there and I can see it straight away. So, and just become a routine now. We do it and we put an X and we mark all the spots. And then we make our incision according to that.
So this is on the table, you're doing the ultrasound?
On table after the patient is under GA, yeah.
Excellent, excellent. What a great idea. I think you should publish this. I have not come across this anywhere.
Oh no, sir. Actually, everyone's doing it in the conferences I go to, so it's something I learned from them.
Fantastic. And tell us about your drain positionings. Where all do you place your drains? And are you worried about seromas and things like that? So when do you take your drains out?
So Jenny, the output of only a few patients get drains, like I mentioned earlier, and so I'll put them right above the plates, and then you cover it with the muscle.
Intercostal?
And most of the intercostal. So not in the pleura. No, not in the pleura.
Oh, not in the pleura.
Chest tube or
all drains. Okay, what do you do?
So if I enter the pleural space, I will put in a chest tube. Okay, so that's a given. But sometimes I don't enter the pleural space. And when I don't enter the pleural space, I'll just place the Radivac drain, not above the ribs, so extra thoracic, and then cover it over there. The output of the drains, really, most of the drains come off by day 2, day 3, because the output is not a lot, surprisingly. And I put always a pressure dressing. So that creates a compactment area. So we just pull it out quickly.
And so what is your criteria for pulling out the drain?
I don't have a criteria. It's just purely on eyeballing it, actually.
I see. You don't have some sort of a less than 50 ml or something like that. Have you had? Sorry.
I actually the number actually to me really doesn't count, actually, because I think with the pressure dressing, I think we're fine, and I haven't got high output drains from fixing ribs actually.
Have you ever had a seroma formation?
No, the only one I had was the subphrenic collection, like I showed you.
Okay, so you just put one single Radivac and maybe an intrapleural drain, depending on whatever is needed. I loved that video where you showed the soft tissue retractors. I mean, again, excellent idea.
Yeah,
excellent idea, I think. And there are some questions from the audience. First question is, do you really need to fix posterior fractures?
Okay, so this is very important we get it clear. So if we get a flail fracture, first, I'm going to start with a flail fracture. If you fix only one part of the flail, if there's 2 fractures in a rib and you only fix one part, what will happen is once you, the muscles will start to pull the fractured rib away now again, and that will cause a severe fracture. So when you fix the rib, you must always fix all the fractures on that rib. Number one. Posterior fractures, look, if you're new to the game and the fractures are very close to the transverse process, just leave it alone, because you're never going to find a place to implant it. But we have started implanting the plate onto the transverse process in severely multiple posterior fractures that are displaced. So I will address it. And you can see most of my x-rays that I've shown are actually a lot of posterior fractures that are fixed. Only a few of them have implanted onto the transverse process, but most of them I actually find enough space to implant the plate posteriorly.
So you showed us a whole range of devices available, and I believe you use the matrix system.
Yes, sir.
So why do you choose one over the other? You know,
Actually, I don't have an option.
As a surgeon, how do you decide?
Okay, firstly, I don't have an option because that's the only one available here. But,
yeah, sure,
now going for conferences, I can see that the good thing about the matrix plate is that it has a screw and it's locking in. I think that's very important in stability. The Judet struts have clips, and they clip, and from what I've discussed with many people, sometimes they feel that the clips actually, even that, can get loose and they can bend, and it doesn't hold it as tight as possible. The rib lock, again, I don't have any experience from it, and all I have is data from the literature, and I think a lot of reports on fractures have been going on there. So, you know, what I guess the only thing I can speak on is the one I know. So, and the reason I use it is because
you have any experience with the Stratos system?
No, they don't have it here in Singapore, unfortunately.
I see. Okay, all right. I just 1 second. I want to see if Dr. Shyam Kulvikar is with us on the call or not. No, he's not. So let's just continue. So the next question that they're asking is, we've just done all.
So I've got a question here. Do you need to fix all the ribs, or may just be alternate ones to minimize surgical trauma above the original trauma? I don't think you're going to cause more trauma. And if you're going in to fix, you might as well fix everything. Alternating fractures is converting a flail into a simple fracture. And if you're going in to repair it, you might as well go in and fix everything. So again, this has been, your question, I think, has been asked quite a bit by many people in conferences. And I think most of the experts who do this with fixation tell you that fix all on your way in.
The next question is, I see really long lengths of matrix ribs. Once you're doing for fracture, maybe just a 5 to 6 centimeters should suffice. Your comment.
Okay, so the matrix ribs have very long ones. They usually come in a long plate that has about 12 to 14 holes, depending on it. And what you do is we cut for just single breaks, we cut the plate and we use 7 holes. So 3 holes on one end, 3 holes on another end, and the 7th or the center hole will be over the fracture component. So they're short. Now, what you see is when you see long, I generally don't, maybe I should bring back my x-rays, but unless I'm bridging a long or a flail fracture, I'll use one plate. But most of the time I cut it and I fix both sides.
Let me clarify that. They have misunderstood, because the x-rays that you showed was chest wall reconstruction following surgery. Okay, that's a completely different scenario. So there you've got a big hole, and then you have to use whatever has to be gapped across. Go ahead, give us your opinion on that.
Oh yeah, of course. I mean, if you, what I showed you was I wanted to show you my complications that I've encountered. And so the one with the extra long plate was absolutely what Dr. Khan just mentioned. We're bridging it. That's it.
Yeah, sure. So it is not for rib fractures. That one was for reconstruction of the chest wall. That's a completely different situation. Ramaswamy is asking us, in the case of compound fractures, comminuted fractures, how do we assess the viability of fracture segments and plan for chest wall reconstruction?
Okay, so now in compound fractures, so Do you want me to talk about the management of a compound fracture in a rib, or do you want me to talk about what happens in the community?
Yeah, he wants to know the viability of that fractured segment.
Okay, so you have to resect it. I think if they go into bits, it's going to be all over the shop. And then what you don't want to have what you call bone fragments or shrapnels going in there, and that forms a different callus altogether, and that creates another big scenario. So generally, I would resect that shrapnel component, or sorry, the comminuted fracture component, leave a small gap, and just bridge it with the plate. Or if you can bring it slightly closer together, you actually may heal.
I love that case of yours, the one with the degloving injury.
Yes, yeah.
I saw that long incision that you had to make to get access. But also in the second picture of that slide was a vacuum pump on it. I'm assuming that was before you put in the plates, isn't it?
That's after we what you're seeing, that vacuum pump is actually it comes from the company that makes vac dressing. And what the plastic surgeons do is they place that vac over the skin. This is after they close the skin already.
Oh, it's on the skin.
It's on the skin, and that actually prevents seroma and a lot of other things involved in it. So it actually helps with the healing of the wound.
Oh, is that correct?
So
I was trying to figure out that long vac pump. What's
the name? It's called a pico dressing. I think pico dressing. I can look it up and I'll send you the details on it.
I thought maybe it was a couple of days before you put in a vac pump and drained out the.
Oh no. That's after it's closed and they put the.
Oh really? So vac dressing on top of a skin. Wow. I have not seen.
Pico dressings. I can't remember.
Oh, all right. That's very interesting. Okay, I've got one question on the chat. I'll just bring that up. Everybody, please write it on Q&A because I can't go between the things. So, Dr. Akramul Haq from Bangladesh, Dhaka, a very renowned surgeon from Dhaka, he says, though we have no such device, we are not practicing it, but we are combating fracture ribs. Excellent lecture. Okay, so he's saying great stuff. And I think the problem in the Southeast Asia is A, availability, and B, cost. Very often I've had patients whom I could, offer them plates, but many a times the cost of the operation becomes exorbitant when you have to use 8 or 10 plates, because each one is about 1 lakh in Indian rupees, which is about 1,000 pounds. So it becomes very, very expensive when you use 8 or 10 plates. But you have to do what you have to do for patients. So I think this was
product available in India now.
Yeah. The plates are available. It is available, but you have to order it pre-hand. They're not freely available. You have to order them. It's usually used by the orthopods who are doing, vertebral column injuries and all that stuff. But it is available. I've used them. But I've used a lot of K-wires. So, many a times I've fixed with K-wires. I've used Ethibond as a material to hold ribs together. So over the years, you use different things that are available to you. The one thing is, you said something about in polytrauma. I wanted to ask you, most of our patients have associated injuries like neurosurgery and head injuries and abdominal injuries. And I think I saw in your slides that it was one of your contraindications for rib fractures.
Yes.
Is that correct?
Absolutely. Yeah.
Okay. So just wanted to make that point for the youngsters that when you have polytrauma, you don't want to jump in and fix ribs.
No.
You first have to get rid of the other issues.
Fix everything else. You are last in queue.
Yeah, you're last in queue to do that.
You're last in queue.
Right. Yeah. Because that is an important point. A lot of us see polytrauma rather than this. So thank you very much, Harish. Is there any other questions which people want to ask? I'm quite happy to. Okay, Dr. Bhate says it's a pico dressing used in obese patients post CVTS surgery too.
Yeah, pico, that's the one.
Yeah, okay. And Dr. Ramaswamy is again asking us, do the stainless steel alloy plates give the same strength and results? And they're less costly? Your comments?
Again, Dr. Ramaswamy, I apologize. I have you talk stainless steel alloy plates. I've never used them, so I only use the matrix rib. So I am unable to comment on the different types of plates in the market.
I think what he's asking about are the ones that you use for clavicular, fixing clavicular fractures and small bone
right.
fractures, like tibia fractures and things. Can you use them on the rib?
No, because they have a very different the thickness, the pliability, and understand one thing different about the ribs is that it's a moving structure. It's continuously in motion. If you don't contour it properly, then the failure rate becomes high. In fact, that plate can in fact fracture the rib further. So you don't want to, you want to have a pre-contoured plate with a very thick, thin, what's the level, a thin plate to be able to move and be a bit malleable according to the moving rib. It's not like fixing a humerus fracture or a femur fracture where those bones don't move. They're stable, right? Whereas the ribs are in continuous motion, and that's what they find difficult.
So using these small plates don't work on the ribs, to be really honest. That's been our experience. I have tried them in the past and they don't work. You cannot bend them. They are not malleable enough to contour to the shape of the rib. What's your take on 3D printing in this scenario? Is there any role for 3D
Actually,
printing?
I wanted to talk about the future of rib fixation, but the area was very, very small. So people are thinking and talking about absorbable plates, where they're designing this. So they're 3D printing the plates and implanting it in, and these plates eventually get absorbed after a couple of months or maybe longer than that. But the difference is that how are we going to see fracture ribs happen during you got to attack them within 7 days. And number one. Number two, how do you 3D print a patient's scan if it's already traumatized? So he's already got multiple fractures and everything's distorted. So can you actually get the real anatomy back? You need to probably have a good program that can design it. And then you got to send it in for printing. So it's definitely out there, I'm sure. I think whatever it is, 3D printing is the future. I'm pretty sure it'll work.
I think the way you design it is on the basis of the normal side. So you look at the normal side and you have a pre-existing symmetry that you expect on the affected side. And so you use the normal side and then mirror it to the affected side. That is how 3D printing will probably be able to give you an estimation of what should the chest look like. So no, these are very interesting things. Thank you very much for a really, really good talk. Before we end, I just again want to summarize. Please understand that there are a lot of devices available out there. These are things that we see every day in our clinical practice. The three main indications for fixing ribs is inability to wean off ventilator. Number two, a flail fracture. And number three, intense non-resolving pain. And the important thing is, if you're going to fix it, make the decision early. Okay, because as he said, the real benefit of fixing a rib is you're able to get the patient off ventilator sooner and you're able to get him out of hospital sooner. No point delaying that decision to later, because then the patient will develop ventilator-associated problems like pneumonias and things like that. So be very proactive. And if you think that it needs to be fixed, if the thought comes to your mind, start mobilizing things early. And he waits for 5 to 6 days. I think that's a very good call. That gives you enough time to understand whether this patient will recover or not recover. And then you can, go in after that period. So thank you very much, Harish. It was a great lecture. I really enjoyed it.
Thank you, Dr. Kant. Thank you for inviting me.
We would love to have you do more talks with us in future. Please pick up topics like these. These are really good topics where there's not enough literature available out there for the young generation to make clinical decisions. Thank you very much. And I'm going to sign off once again on behalf of everybody. Thanks. Bye.
Thank you very much. Okay, bye-bye.